Hello and welcome everyone. We are going to wait just to have a couple of more participants hop on. But in the meantime, please feel free to let us know where you are watching us from. We're always curious in the chat box. So you can always add that in. There's a little chat box icon towards the bottom of your screen, and just let us know who you are and where you are watching us from. We're excited to know. And we'll wait about a minute or so. We're going to wait for everyone to hop on. Denise.
Toronto.
Super cool.
Blue Jays.
Awesome. Keep letting us know, everyone. You can add it in the chat box if you'd like. Alyssa from Maryland, hello. Glad you are here. Michelle from Toronto, okay, that's awesome. Oh, we got a lot. We have Idaho, we have California. Stephanie from...
Stephanie's here. Hello, Stephanie.
Lisa from Vancouver.
Vancouver, BC, because I'm in Vancouver.
Awesome. Super cool. Hello, Stephanie. Welcome. All right. So we got a good little group going right now. We're still going to have a couple come in. But I'm actually going to get started because we have a really great presentation today, and I want to go ahead and give enough time to our presenter. But welcome, everyone. My name is Bianca Gonzalez, and I am the Bullying Prevention Program Coordinator with the Riverside Medical Clinic Charitable Foundation. Welcome to our Endometriosis Family Support Group webinar. We are so happy to have you on here. And first off, I just want to thank our wonderful sponsors, the Riverside Medical Clinic and AbbVie. We truly appreciate your support. And then just a couple of logistics when it comes to Zoom. We're going to be utilizing the chat box a lot during this webinar, so a lot of you are already familiar with it. Any questions or comments that you may have, please share them in the chat box. We'll be doing a short Q&A towards the end of the webinar, so please feel free to save those. And I believe we're going to have a couple of polls too towards the end of the webinar too, so just keep an eye out for that. And I want to go ahead and introduce our presenter for today. So our presenter for today, Wendy Bingham, DPT, founder and executive director of Extrapelvic Not Rare, is here with us today, and we're really excited, and I want to share a little bit about her. Dr. Bingham is an advocate of endometriosis. Her journey with symptoms began at age 17 years. Unlike a large portion of persons with endometriosis, she did not experience regularly painful and heavy menses. While her symptoms generally occurred around the menstrual cycle, her symptoms were always associated with the intestinal tract, urinary, and respiratory systems. Fast forward nearly 30 years without a diagnosis. Following a history of recurrent lung collapses, multiple misdiagnoses, and dismissal of her concerns, a rapid decline in health led her to the Center for Endometriosis Care in Atlanta, Georgia in 2016. Her own struggle for diagnosis, recognition of the many barriers to diagnosis, and treatment for atypical endometriosis. In 2018, Dr. Bingham established Extrapelvic Not Rare, a 501c3 charity organization to promote awareness, education, and facilitate research into and recognition of presentations of endometriosis that lies outside the female reproductive system in local areas. So with that being said, I will now go ahead and give it away to Dr. Wendy Bingham.
Hello, thank you. It's wonderful to see everybody here. I've got to figure out how to work my screen and get my head on. I think I left my head in the other room. Let's see here. I want to share this. And so we can show us what else is said. I'll pin less. So I'm going to share my screen here. Welcome from Zoomland, everybody. Wherever you are in the world, I'm very thankful for your presence here today, and hopefully I won't stutter over my own tongue today. It's not the nicest day in the world from us in the Pacific Northwest here, but it's dry at least. So having said that, I am going to begin. We have a lot of information to share, and we did have a couple surveys we were going to try to put up. We're having some technical difficulties. So we're hoping that Bianca will be able to sort that out, and we'll be able to have participants take place with that survey today. So today is the beginner's guide to thoracic endometriosis. When I say beginner's guide, I want you to think about the New York City yellow phone book. It's pretty big. There's a lot about thoracic endometriosis that we do and do not know. But there's a lot of general beginner's information that I want to share with you. And the fact is that if I go too fast or too slow with something, and you want to look deeper into specific slides, each slide has references. They'll have a reference number. So for example, if you look in the right-hand corner at the bottom, by the page number, and you say, oh, that's slide 13. Then you go down to the very bottom of this presentation, you will see those citations that I used for that slide listed in an ABC order. I think that that's a lot easier than to go through and clutter it with the specific citation on each slide, as well as if I was to number from 1 to 80 through the slide presentation, it's a lot harder to remember those numbers than just being able to peruse, find that slide that you liked and you wanted to learn more. So there, I wanted to tell you that in advance of this. So let's begin. All righty, so I gotta go. Now if I can figure this out here, gotta find my, there we go, okay. So as I noticed, the first survey was really to get a feel of who's here with us, from what area of the world that you're visiting us from, as well as what your background is, if you're a patient, person with thoracic endometriosis diagnosed or presumptive that you may have it, or that you may be a healthcare provider. So hopefully we can do that later. So I do have some objectives for this. I think it helps people keep on track with what we're going to discuss. The first and most important part I have is understanding what really is pelvic and extrapelvic endometriosis. Then I'm going to hone down into what specifically thoracic endometriosis syndrome consists of. There's a current definition, as well as some proposal to expand that definition. I will then go through the presentations of the primary presentations that are currently under the definition of thoracic endo. And then we're going to talk a little bit about diagnosis and treatment interventions. So, oops. So first off, extrapelvic endometriosis. When you hear this term, it really depends on the person that is presenting the information. This is the information that is given in the literature, scientific literature. So the definition of extrapelvic can differ between who is doing the actual study. So there is no true definition of it. It's defined by the scientific writer at the time that's doing it. But when I refer to extrapelvic endometriosis for my nonprofit organization and just in general, I have my own working definition that has been consistent through numerous writers over the past few decades. So pelvic endometriosis is defined as the typical pelvic endometriosis that you hear about. This is involving the uterus, the fallopian tubes, the ovaries, the peritoneum, like the pelvic side walls, the cul-de-sac, which is in front of the uterus and behind the uterus. By Markham's definition in 1991, he basically said extrapelvic endometriosis is anywhere else in the body. So having said that, I found that that was easier to communicate to people. So let's see here. So Yazdananan in 2014, he expanded that a little bit. So when you think of the first definition, okay, that means everything. Well, what really does that mean? So these are some examples to make it a little more concrete to you. So extrapelvic endometriosis is divided as presence of endometriotic lesions found outside the pelvic. Notice that it's a C. It's not a pelvis, as in the bony anatomical pelvis. It's the pelvic definition that was already pre-stated. So other places that are examples are the cervix, the vagina, the vulva, which is the exterior genitalia, the intestinal tract, urinary tract, the abdominal wall, the diaphragm, inguinal canal, which is down where your hip, the crease of your hip is, the thoracic region, so your lungs, in the limbs, and your nervous system. So these are just examples to make it a little more concrete for you. So based on the literature that's out there, we truly do not know the prevalence of extrapelvic endometriosis. This has to do a lot to do with the fact that most of the information comes from large university centers that have multiple disciplines available, so that when they are able to address disease in all these areas, they're able to keep track on their own statistics. However, to date, we still do not have a universal system in place to say, endometriosis occurs here and here and here. What I mean by that is we do not have anything from a national level to a global level to track endometriosis in the majority of extrapelvic locations. So the going rate is about 20%. So this range, as you see, can be 5 to 37%. So when we at least have to have some kind of a grasp of a number to work with, and 20% seems to be the average that you're seeing in the literature. So now you take extrapelvic endometriosis and you say, okay, well, we know that it affects all these different areas of the body. So now we look at the different systems in particular. So within the digestive system, it is the most common area, particularly the intestinal tract. Followed by closely behind is the urinary system. We also include the excretory system, which is the kidney, although it only takes 2 to 4% that we know of estimates for urinary system involvement. That's included here. So when you go down to the respiratory system, that is third, followed by the skin. And then we kind of clump in everything else that goes along. So we have a lot of peripheral nerves and muscle tissues, particularly the pelvic floor, that is involved with endometriosis. But again, truly, we do not have a way to record consistently every episode that exists. So if you were to take the estimates, and again, there's no concrete way to know this, but if you look at the distribution patterns, our infographic, Trish here is great at helping us with this. So you look at the blue here, the blue cloud, it's kind of a crampy sensation. That's intestinal disease. So this takes the largest proportion, followed by the urinary system in the green. And I like to use the pointy one because I think of those sharp stabbing pains a lot of people have when they're trying to urinate. That is a strong indicator of urinary endometriosis. So this is the green here. Then you have the lightning bolt here is the red, and this is particularly what we're going to talk about today, respiratory endometriosis. And I like to look at the lightning bolt because that is a good representation, I think, when you look consistently at certain symptoms that present with thoracic disease. Then I have this little star here, 4-pointed star, and he's the cutaneous system. And I like to use that as a symbol because a lot of people with cutaneous endometriosis describe that painful stretching sensation as the lesion expands and contracts throughout the month. So we've put these in here, followed by this little tiny slice here that they say is other, which is neural endometriosis, muscular, all the oddities that are left out. So when we look at endometriosis specifically to the respiratory system, once again, there's no universal documentation to know. So the estimates that were given based on numerous literature, we look at patterns over time, and the current estimates are 2.3 to 5%, 5.6% of people with pelvic endometriosis will have endometriosis affecting one or more tissues of the respiratory system. As I stated, we do not have recording for that. We also know that there's poor awareness and knowledge about thoracic endometriosis. So given this fact, we know that general surgeons, thoracic surgeons, other healthcare providers outside of gynecology will also encounter thoracic endometriosis, but they're not added to the literature and they're not being recorded at multidisciplinary endometriosis centers to keep track of statistics. The most important thing that we want to stress about respiratory thoracic endometriosis is that it's primarily a catamenial presentation at first. What we mean by that is the word catamenial refers to about menses. So the catamenial period, there's a distinct number of days that you tend to have symptoms that present when you first start to have the disease become symptomatic. Now, that doesn't mean that it stays only within those days known as catamenial, but that will change with time as the disease progresses, and we'll discuss that later. We also know that there are a lot of imaging limitations to the disease. A lot of medicine today is using imaging as what they call diagnostic imaging. And realistically, diagnostic imaging is there to support or refute a possibility disease exists. We know with thoracic endometriosis that there is a tendency for persons to not have their disease found on imaging. So this is important to consider, and the fact that these estimates may truly be lower than they really are. Another concept is that a lot of people, surgeons that go in and they look for disease, they'll look at the diaphragm and they may look right at it and go, that looks like just scar tissue, when in fact it could be atypical presentations of disease itself. So having said that, if they're not locating the disease, it's right in front of them, but they're not recognizing it, this also affects statistics. The last one, and we're going to touch a lot on this, is the laboratory tests. So a surgeon may go in and they'll biopsy a sample area, and they'll come back and say, well, it was negative for endometriosis. So the question becomes, one is first off, what tests did they do? Did they just do histology tests? Did they immunohistology? Did they look at the aggregation of the cells? Those are really important. And the second thing is that it's minute cell rests that affect the organ, and that they may have pinpointed an area that isn't being looked at under the microscope. So having said that, there's a lot of misdiagnosis as well as undiagnosis that occurs with this condition. So if you were to take 100 people that have endometriosis in a nutshell, and you see the nice thunderbolt, this is what we would think, that this is the number of people currently estimated to have endometriosis of the respiratory tissues. So it doesn't look like many. Having said that, when you look at the United States of America, I've quickly put this together right before our presentation. The 2020 population estimates based on the US Census is that there's 328.2 million people in the United States. 52% of those are female, which is 170.7 million people. Persons who are assigned female at birth, the only category I could get was the 18 to 65. So we know that we're going to have people that are symptomatic that are adolescents, and we know that there's going to be less people above 65, and they're going to be closer to maybe 60 and under. So if we shift that age graph a little bit, we know that there's 131 million people with between the age of 18 and 65 who are assigned female at birth. But if you took 10% of them, it's 13 million people have endometriosis. Now, if you were to consider out of those 13 million people with endometriosis, and you break it down to, well, how many are affected by disease in the respiratory system, we estimate between 302,000 to 735, almost 736,000 people in the United States have disease affecting the respiratory system. And again, this is an estimate based on the ages of 18 to 65. So there'll be a slight shift, but I think that the statistics are important to really consider looking at that and look at how many of our healthcare professionals are prepared to recognize and treat the disease. So let's look at the respiratory system. And if you look at the reds and the purples, you'll see that these are all representative of locations that disease have been found in. The areas that are in purple are very infrequently reported. And again, because we don't have statistics, we can only rely on publications. We know that publications aren't every single case of each of these that occurred. So, we have to give or take a little bit, but we have, nasal endometriosis, that's nose bleeding, but there's usually pain with that. And that's separate than what we call catamenial epistaxis. And I'll talk about that later. We also know that it has been found in a few cases in the trachea. I included the esophagus here, which is a digestive thing, because one, it's on the map here on our diagram, and it's something that I need to bring up because it's atypical. But the majority of areas, if you were looking here, are particularly the diaphragm, followed by the pleural lining here, which is called the parietal pleura. Then we have the visceral pleura, which are in the linings here. So it's the outer lining of the lung itself. And then we have what's called internal bronchi. So your left and right bronchus is where lesions form in the airways. And we also have lesions that form within the lung parenchyma itself. The heart isn't pictured here, but we are aware of pericardial endometriosis. To date, according to the surgeons I've spoke to and everything I've seen in the literature, all pericardial heart disease originates from the abdominal side of the diaphragm, which if you look at my arrow here, following this is the abdominal side of the diaphragm. So that diaphragm is, the kind of that brown sheet there, and it separates the thoracic cavity from the abdominal cavity. There's about 6 cases of published pericardial disease. However, we do know that there are more than that. They're just not in the literature, and that they are being seen and treated by multidisciplinary excision surgical teams. But I can't give you an exact date or exact number, sorry. So if you say, okay, well, I have endometriosis of the respiratory system. So what tissues are involved and what's the prevalence? First off, we know the probability is going to be for thoracic endometriosis that we are aware of is the higher your ASRM staging, that pelvic endometriosis staging. So if you're stage 3 or 4, you're more likely to have disease of the respiratory system than say a stage 2 or a stage 1. We do know that there are cases where endometriosis is found only in the respiratory system and has not affected the abdominal pelvic cavity. When you were to look at now of those tissues, what's affected? I chose to avoid percentages here because I find them very, very confusing, and they're all based on the number of people within a study. And there's kind of like a little bit of a bias because it has to do with those patients that have actually gotten to the multidisciplinary centers and have had that disease treated, and that center is keeping track of that data. But when you look in a nutshell, we can say the diaphragm is far more than any other tissue affected by the disease. So that's why I have 2 arrows here. Next comes the chest wall, which is that parietal pleural lining and the inside of the chest side of the diaphragm and the parietal pleura. Next is the lung surface, which again is that what they call a visceral pleura, as well as within the lung itself, the lung parenchyma. And the least is the airways, those bronchi. So when a surgeon goes in to look for endometriosis, they may find lesions or they may find other relevant things to indicate that there's a pathology going on, that there's a disease present. These include the formation of blebs, which are little balloon-like areas of weakness of the outer part of the lung where air is coming in and it's going into an area of the lung, and the air could be getting trapped. And that trapping leads to a balloon sensation that builds and then that ruptures. There's also bullae, which are a breakdown, a whole bunch of little air sacs from a small bleb area of weakness to a larger and larger area. So they're a bit bigger than a bleb. There's also scarring that shows prior injury to a lung. There may be the lung scarring of the lung to itself to the wall of the chest that shows that there's been repeated injuries and repeated lung collapses, as well as the adhesions that form from the healing process. So thoracic endometriosis syndrome itself, the current definition is comprised of what they call manifestations. A manifestation means it's something that can be seen on imaging. They can hear changes in breath sounds. They could take an X-ray or a CT scan and they can find something on there that's not normal. Or in the case of coughing up blood, that might be seen on imaging, but you can actually see the blood there. So if you look at the current syndrome, it's limited to the 4 items. So a catamenial pneumothorax, catamenial hemothorax, catamenial hemoptysis, and lung nodules. Again, catamenial refers to this period of time leading immediately prior to the start of your menses and through the beginning of your menses. This is a period of time that these events occur, with exception to pneumothorax. This is when the disease is active and likely to be seen on imaging. When I refer to lung nodules, we'll talk a little bit later about that, because there's many different causes for lung nodules. And in particular, there's a way to detect whether a lung nodule is active or it's just inert and it's benign. So we'll discuss that later. So this was done 25 years ago, and I really feel it's time that we update this statistic because I think as awareness is slowly improving, we need to get larger and larger gatherings and reevaluate the distribution of these different manifestations. So of the 4 original thoracic endometriosis manifestations, we know that these manifestations are only a small percentage of the total number of people that are experiencing endometriosis in the respiratory system. In other words, not everybody who has endometriosis in the respiratory tissues is going to suffer a lung collapse, or is going to have blood accumulate in the chest, or is going to cough up blood, or we're going to have lung nodules that change characteristics and expand back. This is just a small portion of those people. So out of those manifestations, the pneumothorax is the highest prevalence. It's much more frequently for somebody to come to the ER with a pneumothorax than a hemothorax or coughing up blood. So out of the distribution, you can see that coughing up blood, as far as we're aware, is the least common manifestation versus blood in the chest or a leaking lung. So the proposed addition a few years ago, we've had this presented by multiple researchers who are pushing to have this expanded, is to add things like pleural effusions, which are when there's not per se a quantity of blood that's mixed into the fluid in the lung, but that there is fluid there that expands between the outside of the lung and the chest wall. We also need to look at diaphragm herniation, which most commonly involves persons who have late stage diseasing, a disease that of the diaphragm that wasn't treated. And because the diaphragm is literally millimeters thin, the integrity of the diaphragm is reduced as the lesion grows and becomes more and more fibrotic. It suffers weakness, and therefore, when we're in a position like sitting, the liver is being pushed up into the diaphragm. And if the diaphragm is weakening, there's a possibility of the liver projecting into the thoracic cavity. And this may accompany a lung collapse in addition. So I am seeing this in my support group, and the literature is starting to show more of these reports. The last one, which is, I think, takes the largest majority of people with endometriosis of the respiratory system, is the cyclical catamenial chest pain. It's coming on with my period and then it fades away. And again, this is how it often starts. And for some people, it progresses to larger and larger periods of time through each month. And we'll talk a little bit about that. So having said that, this is survey 2, so we hope to get to that at the end of this. So we'll just move on. Having said that, this isn't to scale of percentages, but this gives you an idea of if we were to take a population of people with respiratory endometriosis and their presentations, you're going to see that catamenial chest pain is by far the largest percentage of persons that are presenting. Next in line, you see the second largest is pneumothorax. And in addition to a pneumothorax that occurs during the catamenial period, thoracic endometriosis is even more complicated because we have what's called endometriosis-related pneumothoraxes. And these are ones that can occur at any time through the month, and not just the catamenial period. The catamenial has its own defined area, but endometriosis-related pneumothorax has an all-encompassing definition, and we'll talk about that a little bit later. So the first, I'm going to start from the least common to the most likely that you're going to present with thoracic endometriosis. I think it's important because most people will have questions related to the more common presentations of the disease. So I know people probably have seen Chicago Med recently, about maybe a month ago. They released an episode about Catamenial Hemoptysis. There were a few accuracies, but there were also a lot of inaccuracies about the condition. So hopefully today this helps set some things straight. So hemoptysis again is coughing up blood at menses. And when I have people, constantly asking in my room, how much blood or what does it look like? People have found that they could have clear sputum with just tinges, pink tinges to red tinges of blood present. Some people have reported coffee grounds that they cough up at menses. And I've seen reports as high as to up to a cup at a time. That is a very rare scenario. Most often it's, 5 to 100 millimeters of blood coughing. For most people, this occurs on the first day of their periods. We do have reports on either side, so the day before or when the days following the start of menses, people have a tendency to cough up blood, but it's usually the first day of their period. They also have a tendency to report, the shortness of breath, the difficulty breathing, which makes sense if, your airway is being restricted by swelling from endometriosis lesions, as well as the airway being restricted. And there may or may not be chest pain present. In part, this is due to the location of the lesions. We know that the airway itself does not have pain fibers. The internal areas of the lung parenchyma, the lung tissue itself, does not have pain fibers. Pain fibers are present, though, in the outer wall. So we call it the parietal pleura, so the inside of the chest wall. And if it's making contact to an area where there's disease in the lung parenchyma or on the outer surface of the lung, that can be painful. And it can be very painful, actually. We have a very high sensory nerve density within the thoracic cavity. We were built that way because based on the mechanism of fight or flight and survival, our vital organs are in the ribs, within the chest, so they're protected from injury. And so anytime that there's some kind of threat, both external, internal threat to the body, to these organs, there's a high sensory innervation. And so when you say, I have an endometriosis lesion and it's this big, well, the body doesn't know it's this big. All the body knows is it's in this area, and that's not an area that we want to have a condition with. And so the body's going to send all this information to the brain and say, hey, this is really painful. Stop doing what you're doing. Something serious is going on. So the brain is telling it to protect itself the best way it can. So what they did notice is that people with a tendency to cough up blood, there was a tendency in some reports that these people had prior uterine manipulation. So they might have had fibroids removed, or they'd had an ablative procedure to the uterus, or they may have had prior cesarean sections or had retained placentas. But there's also case reports that this hasn't occurred. And so when you look at cause and effect, there's really no one way to say what's the cause of catamenial hemoptysis. Like all other areas of thoracic endometriosis, there's probably more than one reason that the disease exists. There's more than one reason why the disease is where it's located. And so having attested this, the youngest person that has been found to have hemoptysis was 12 years old. So what can be done about catamenial hemoptysis? First off is diagnosis. This is sometimes a challenge, because when a lot of thoracic surgeons would say, well, wait a minute, we need to just do a bronchoscopy. If there's something wrong there and you're coughing it up, we'll be able to see it. Well, the unique thing about endometriosis lesions in the airway is that it's not always visible. It's like magical. It can appear and then literally regress into the lining of the trachea. So depending on the timing of the bronchoscopy can be very, very important to detect disease. And I can say on the side, I have a friend that went through this process, was coughing up blood. The first time that she went and had a bronchoscopy, they didn't see anything. And as you can imagine, us with endometriosis, there's something there. I'm not making this up. It's happening. It's really happening. And so why is this like not being found? And then I'd said, hey, you really need to go back and you need to tell me, you need to time this with my menses. So she had a second bronchoscopy and it was timed with her menses. And of all things, magically, it was present and they saw it. And she actually reported to me that they were all that taken back, that they could see the lesions the second time, but not the first. So I do see in the literature, this is pretty consistent to try to time that with your menses. They can also do, if you have tendency to cough up blood and the lesion is identified on imaging in the lung parenchyma itself that's close to an airway, they can do a image guided biopsy. Most of the time it's by a CT, and they can use a little needle and they can go in there and they can extract a section and biopsy that. You know, that's something that isn't frequently done, but I have seen it discussed. The other thing is for the Catamenial Hemoptysis is that there's a tendency for lesions to show up in what we call ground glass opacities. So in other words, you may have a lung nodule. And what I mean by active is that it changes its appearance during the menses. And I have got an image that I've attached here to show you. So you will see the image, the lesion change and become more diffuse, and it creates what's called a ground glass opacity. And you can do a CT scan when you're not on your period and have no symptoms, and it may or may not show a nodule. And then you can do a CT scan while you're on your period, and if a disease is present, the nodule will be more apparent, it may be increased in size, and the ground glass opacity may be present. So this is why it's important for them to do, you know, if you best can time it when you're on your period and when you're not on your period. So when people tell me, well, I'm coughing up blood, and as you'll find with thoracic endometriosis, there are so many other conditions of different body systems that have to be ruled out for them to even consider thoracic endometriosis. And I know this is really, really frustrating for us as patients, because we go to the doctor and you keep telling them, it's happening with my period, it's happening with my period. And they're still not convinced, like, because they have in their own head and their own training is they have to look at your age, they have to look at your medical history, they have to think of what are probabilities that are more likely to happen and be a cause for what you're experiencing than this far out possibility that you have thoracic endometriosis. So when it comes to coughing up blood, these are all things that have to be considered. Some are more common depending on your age group, and some of them are quickly ruled out. I'm presenting this screen because I want you as a person who's might be seeking care to realize there's a lot of things that have to be considered. And so trying to seek care, it's like finding a needle in a haystack when we first start and we go to a doctor for an evaluation. So they use this mnemonic called battle camp, and I added the E on because it was missing. So we'll start with the lung nodules. I do get a lot of people in my group that ask me, well, I have these lung nodules that they found, and say, okay, well, it's important. First off is, you know, don't jump to conclusions right away. They have to look at what your symptoms are, and they also have to go through the differential diagnosis process. So if you look to the left here, we're going to focus just on this. This is a very busy slide. So if you look at lung nodules, they're very common. Particularly the older we get, the more common that you'll see them on imaging. They're usually defined as an area on imaging that is less than 3 centimeters in diameter or 30 millimeters in diameter. They occur in up to 50% of the images that are taken. So realizing that, it's like, oh, okay, that's pretty common. And we know that there's a variety of reasons for nodules. The majority of these nodules are less than 20 millimeters in diameter, and 90% of them are benign. So I do have patients, you know, that come in and they're scared. They're like, is it cancer? You know, what's going on? Is it endometriosis? So let's just start, you know, looking at the probabilities here and kind of settle yourself into going, what's the process of diagnosis? So these nodules that you have in your lungs, they're often scar tissue. They could be called what's granulomas or calcifications. And basically, when you think about when you have a lung infection, a respiratory infection, a pneumonia, your immune system kicks in and it sends the little Pac-Man white guys in, and they gobble up gobble up the debris. And sometimes what happens is our immune system actually encases the bacteria to kill it off. And that leaves these little covered areas that are coated. And eventually in time, those become little calcifications. So it's inactive disease. If you were to have an x-ray, the nodule has to be 8 to 10 millimeters. So one centimeter in diameter to show up. We know a CT scan can show nodules as small as 1 to 2 millimeters. So what's important when it comes to endometriosis, when the people look at imaging, is they have to look at obviously the size of it, how big is it, what's the shape of the lesion, where the lesion is located, and the appearance of the lesion. The appearance is very, very important, because if there's a hard capsule around it, then you know that it's an inactive nodule that's present. But if it looks a little bit like transitional in lucency, so various degrees of white incorporated in it, then there's probably an active lesion there. So we have now to decide that a lesion, endometriosis, or nodules. So we know that they're going to be less than 30 millimeters and probably less than 20 meters in diameter. So now we go, okay, if there's a nodule there, it's either going to be benign or malignant, or it's going to be an endometriosis nodule, which is also benign. So benign disease also include a variety of other conditions. So I listed a few of these. And malignancies, what we know about those is they grow very, very quickly. So you will see a rapid change in sizes. So if your doctor's saying, well, let's do a CT, and then they'll say, we're going to follow up in a couple of months, and then we'll do a re-image, and they want to compare the sizes. That's giving them an idea of, okay, is this lesion stable, or could it possibly be malignant? And again, they're basing that on your symptoms that you're having, as well as your medical history and your family medical history. Maybe you've been exposed to things in the environment. So now we get down to the endometriosis nodules. As we talked, that the appearance is going to be heterogeneous. So you're going to see variations in the white presentation of it. You're also going to see that most patients are going to report, look, I'm coughing and I have shortness of breath. It's coming cyclically at my menses. The last thing is you may have catamenial hemoptysis with that. So you can have lung nodules and not cough blood. It is possible based on the location of the lesion. And you can also not have pain, or you can have pain. So what I did was take pictures that I thought were really, really relevant. So a person came and said that they were having symptoms at their periods and that the symptoms were regressing. So right before her period started and she became symptomatic, they had a CT image done. And they found this little tiny spot right here. And, you know, based on location, if it wasn't on the periphery and it was more towards the center, you might be thinking it's vascular, right? It's an artery or vein, a capillary type structure. Then during her menses, she had increased coughing. She was coughing up some blood, and she had greater shortness of breath. So this particular area here expanded into this, what we call trigger happy, this ground glass opacity here. So you see how there's no margination on it? And the density is variable between a very thick white density and a little bit, as it branches out, is a little bit clearer and clearer. So they also did this during menses, and they did a one with a contrast. And so before her period, when she was asymptomatic, this little tiny thing here. Because with the contrast, what they're going to do is they're going to bring up all the fluids, the bloods in particular. So when you did it with the contrast, this is what the image would look like during the period. Now, if you were to follow it up, say in 2 weeks, when her symptoms resolve, it'll go back to looking closer to this. So these are things that are basically like a pathognomonic sign that you have endometriosis in the lung parenchyma. So we're going to move on to the next frequency of presentations. And again, it's still very, very small. It's catamenial hemothorax. And this is common when you have disease that involves the pleura, which is the lining of the chest cavity. It is far less common than pneumothorax, but it can also occur concurrent. So you can have a catamenial pneumothorax. None of these are fun conditions, but you can have this condition along with the others. It's a similar presentation for people that have a pneumothorax. So it would be coughing, shortness of breath. The lung feels very, very tight. The chest wall is tight, difficulty breathing. And it is more common on the right, but we also see it like pneumothorax and lung nodules, that it occurs on both lungs as well as on the left-sided only. So a majority of times when you see a hemothorax, there's a tendency for them to want to do what's called a thoracic thoracocentesis, which is taking a very fine needle going in to the space between the lung and the chest wall and siphoning out, syringing out a small amount of blood. When they sample that, occasionally you might find free-floating endometrial cells. This is not I do not see in the literature that this is common, like they expect well, this is what they have, so we're just going to do a syringe, we're going to sample it, and we should be able to see if they have endometriosis. In other words, if it doesn't show cells, doesn't mean you don't have the disease. So now I'm going to go back to that catamenial period that I talked about. I didn't know how to work it in here, so it's with the catamenial pneumothorax. So the original date when you heard of the word catamenial referred to the old period of time was up to 3 days, 72 hours before you started your period, and up to 72 hours after you started your period. So 3 days before and 3 days after your period is that range where you would see the most common presentations for a lung collapse, coughing up blood in the chest, or active lung nodules. Over time, literature has played with this to try to hone in on that window in particular. So depending on the literature you read, it's really important to, just like the other areas of endometriosis with extrapelvic endometriosis, is to see what their definition of catamenial pneumothorax is. So the narrower version that is more commonly used is that within 24 hours before you started your period to up to 2 days after you started your period. They're still collecting data on this, and it's just still, it's just nomenclature. And with thoracic endometriosis, nomenclature has still yet to become consistent. Well, nomenclature with endometriosis still has to be consistent. So as we move on to catamenial pneumothorax, we mentioned that you had the bigger range and a smaller range. So now I'm going to talk a little bit about the endometriosis-related pneumothorax. What's the difference? Well, an endometriosis-related pneumothorax is one that they've been able to acquire a positive diagnosis based on the histology and or immunohistochemical change, histochemical staining. So what they have is confirmed endometriosis cells on the sample that they were able to biopsy. So what we found is, first off, there is no universal testing criteria. There is no universal diagnostic criteria for endometriosis of the respiratory tissue. And I'll talk more about that later. So we don't have a definite diagnostic criteria, and we don't have a universal standard. And we do know endometriosis within the chest cavity can cause a lung collapse regardless of what time of the month you are on. So believe it or not, it's not confined to the menses as you would expect with a lot of other presentations of endometriosis. There are exceptions for disease of the respiratory system. Just one more thing to make it more complicated. So they started pulling data, and they've done a lot of retrospective studies and prospective studies of collecting persons that have come in that have had spontaneous pneumothoraxes. And they looked at people who were assigned female at birth. And according to records, both going backwards and going into the future, that were people who were referred to a lung surgeon, so a thoracic surgeon for recurrent spontaneous pneumothoraxes, they were tabulated. And what they found was that there was a high percentage of people that they thought were primary spontaneous pneumothoraxes that were out in the community. So first off, we go primary spontaneous pneumothoraxes. It's more common in males, tall, thin males, more common in smokers, and less common in persons assigned female at birth. But what they were finding is those persons assigned female at birth, there was a large proportion of them that were having lung collapses due to endometriosis in the chest cavity. So they started looking at their data, and I'm seeing consistently in the literature that when you looked at spontaneous pneumothorax, you would say 1 out of every 4 to up to 1 out of every 3 persons assigned female at birth that had a spontaneous pneumothorax, which means it happened without some kind of pathology causing it, were due to endometriosis. So they incorporated, in other words, those that occurred during the catamenial period and those that occurred throughout the entire monthly cycle. So if we were to break down the portion of people that were misdiagnosed with primary spontaneous pneumothorax, we knew that the majority of them, I'd say 20, if 1 in 3 persons had a primary spontaneous, and they were actually had endometriosis instead. Of that, the 23 to 25% would be during the catamenial pneumothorax period of time that were misdiagnosed, and they didn't realize it was in that period of time. And the other 8 to 10% of those persons had a spontaneous pneumothorax throughout the month. All of those collectively would make up about 1/3 of those persons that were assigned female at birth that had a lung collapse. So this is a significant problem that we're having because there is no data to separate out who has a lung collapse due to endometriosis and who has a primary spontaneous pneumothorax. This is one of the reasons why I created my nonprofit, and one of the reasons why I'm trying to voice that, because surgeons aren't recognizing that. And of that small percentage of all the people that have respiratory endometriosis and have that lung collapse, a large portion of them are going to have a second lung collapse and are going to be seen by a thoracic surgeon who may treat them, miss disease, and do a preventive intervention so they don't have a recurrence. And unfortunately, that can lead to trapping the disease and making it far more complicated for a team, a multidisciplinary team, to go in and remove the disease for if there's continued symptomology. So I'm pretty gung-ho about this. So now we're going to step back, and you hear this in the community, you hear this of lung surgeons. Well, if it's not a lung collapse on the right side, it can't be endo. It has to be, lung collapse has to be on the right. Or you hear the thing of, well, if they don't have a lung collapse, they can't have endo in the respiratory system. Or they're not coughing blood, they can't have endo in the respiratory system. First off, that's all wrong. That's all wrong. But when I go to the specifics about catamenial pneumothoraxes, I'm going to talk to you a little bit about this slide because I want to demonstrate the fact that it isn't all right-sided. And that's something that's really important. While we want doctors to recognize that as being a right-sided reoccurrence, that person has a high probability of endo. We also want to look to the fact that there are outliers out there. I'm one of those that will have left-sided disease. So what I did was find some really interesting studies. And recently, a group in Japan collected 465 cases that they went back through the literature over 39 years of all the literature that reported spontaneous pneumothoraxes, particularly catamenial pneumothoraxes, from persons assigned female at birth. And what we found is a really actual fascinating distribution. Persons who were teenagers, the left side, they had 30 cases all totally reported. And then you went up to a little bit higher in the 20 to 29. And the biggest decade was 30 to 39. Then there was a gradual decrease, 40 to 49. And then they went up to 50, 59 age group. There was a lot less. So one, we know that it's much more common in this age group here. But what is important to recognize is that it's occurring in teenagers, and it's occurring with women that are postmenopause or perimenopausal as well. So when they took these studies, they also looked at it by the sidedness of disease. So they didn't look at lung collapses that occurred in people that were bilateral, because they do exist out there. But what they did look at was lung collapses that occurred on the right side versus the left side. And most fascinating are that those that were adolescents under the age of 20, they had a higher frequency of lung collapses involving the left side versus the right. Then it went down in the next age group and down further and even further up to the next age group. So this really fascinates me because my symptomology onset when I was 17. And although I never had a lung collapse confirmed until I was 30, my symptomology involved the left and the right sides, but the left side was the one that was always onset and always the more problematic for me, and that onset earlier than the right side. So looking at this, I think it's really fascinating, and that as we educate our individuals in our community and educate doctors, they need to be aware that this is a problem that we're seeing in the adolescents, that there is more of a tendency of the left side to be reported than the right. Now, given that they are small numbers, we don't know the real number, but it really warrants you to look at this a little bit closer, and to actually see those numbers better. So when it comes to lung collapses, including both CP and ERP, so again, all the lung collapses revolve around any time of the month, whether it's the catamenial period or elsewise, and her endometriosis related. The youngest reported case I saw was an 11-year-old, and very, very traumatic. When I read her case, that they had not realized what was happening to her until she'd had multiple procedures. And it hurts me because I realize how traumatic that must have been for her, and to have the repeat occurrence and the devastating amount of surgical interventions that she received to address the issue was overwhelming for me to see that at her age. We also want to note that it does occur. Literature is report that occurs after menopause, both with and without HRT use. Another thing that they found is that, again, we talk about how do we diagnose the disease? How do the surgeons diagnose this? Well, when they go in to do surgery, are they able to recognize the disease? And are they sampling, or if they see an area and they sample it, are they flagging that particular area to be tested? Now, if they're testing it, what are they testing it for? What kind of things are they looking for? Are they looking for just glands and stroma? Are they looking at aggregate patterns? Are they looking at specific immunohistochemical responses, estrogen and progesterone? So these are all important, as well as it is important to note, sometimes doctors go in and somebody may have had a lung collapse and they can't figure out why they had a lung collapse. So they may have, the tissue may look normal. Part of this I question, just like catamenial hemoptysis. If you're going in there at a certain time, it is known that the parietal pleura has some fascinating lymphatic and vascular channels, very numerous channels. And just like how it regresses into the walls of the trachea and the bronchi, is it possibility that you have disease that's sitting within the lining itself that is able to literally fade away so that it's not visible upon a close inspection with a scope? These are all things I have to ask, as well as, they have to look at the diaphragm integrity. We know that there's a tendency that if you only do a VATS or you only do a LAT and you look at the diaphragm, you actually may miss fenestrations, holes in the diaphragm. But if you're doing both of those, one and the other, there's a tendency to increase the percentage of likelihood you're going to detect these small holes. So the most important thing is if somebody has had this recurrent pneumothorax, they had a VATS, and the doctor's like, well, I didn't see anything. First off, if you're having it recur, I would highly suggest you to try to find a team and go to somebody who has a thoracic surgeon on board that is experienced with endo. But what we also find is that doctors will go in a second time, and in that second trip to surgery, there's a higher frequency of identifying the disease. It's not clarified if whether on the second time they're at a different time of the month and the disease is more visible, or if the fact is that they're testing, maybe they're added a little bit more testing, or they're able to biopsy something that they didn't really look at closely before. It's really unclear in the literature about that, but it does show that you're having a second VATS, that there is an increased diagnostic rate. So when it comes to CP and ERP, what's the difference between a lung primary pneumo and a spontaneous or a secondary pneumo? First off is the recurrence. So a primary spontaneous pneumothorax is one where there's no disease involved. So again, it's benign. They don't know if they're little blebs that you were born with congenitally, or if they occurred most particularly in men. People are assigned men that grow rapidly through the torso, and so their lungs undergo different pressure points, and they feel like that adds to maybe creating some lining, little pockets of weakness in the lung, that ends up being lung collapses. So there's only about a 5% recurrence rate, whereas those with catamenial pneumothorax and those with ERP, at least 1 out of every 4 or 1 out of every 3 of those will reoccur. And so what we mean by recurrence is it's the same side of the chest that's involved. So that right there is a red light to say, I got a secondary pneumothorax, it's on the same side. The surgical team, the care team should be moving towards thinking about endometriosis, particularly if you have signs and symptoms in the pelvis, as well as it occurring around your period. So what does a lung collapse look like? I thought I would share this, and I like the fact that they put panic film here. First off, we do know that it's about 1 out of every 3 primary spontaneous pneumothorax have been misdiagnosed that are truly due to endometriosis. Second is the majority of lung collapses. I don't want people to freak out when you see this. The majority of lung collapses are small to moderate. There are occasionally larger ones. If you have recurrent, there is a tendency for them to expand a little bit with each recurrence. But you don't often see what's called a tension pneumo, and this would be where the air so this is the lung that collapsed, so this pocketing here of the heart would shift. So there would be a shifting of the mediastinum, so the heart and everything undergoes pressure from excessive air. It does occur, but it is not something that is a common thing in our condition. So this little area right here is the little lung. When all the air has been pushed out of it, the air has accumulated into the chest wall, and as the air pressure grows, the pressure is pushed onto the lung, and then the lung shrinks down. So just a brief overview. This is very, very busy, so I'm going to run through it real quick. A primary pneumothorax, what's the difference? Okay, there's no underlying pathology that causes it. It's more common in persons assigned male at birth than female at birth. It's more common in people who smoke. It usually doesn't reoccur, and it usually involves one side. There's no preference, like right-sidedness or left-sidedness. Whereas CP and ERP with endometriosis conditions, we know that there's an underlying condition. Endometriosis is present. It is exclusive to persons assigned female at birth. So this does include people who are transgender or people that are non-binary. But we do not know to date of anybody who is truly assigned male at birth that has had endometriosis discovered in the chest cavity. So therefore, we are safe at this time to say it's exclusive to persons who are initially assigned female at birth. These people often aren't smokers, and it makes sense given endometriosis. If we add smoking on top of it and the complications that can cause, that just only aggravates the condition. We know that, up to maybe an average of 30% of them will recur. And overall, there's a high predisposition to be right-sided, but we do see that it's very common in adolescent in particular to be left-sided. As well as you may not be diagnosed with pelvic endo, but we are seeing persons now in very isolated areas that their lung collapse has led to them being diagnosed of pelvic endometriosis, both silent and symptomatic. So there is improvement happening. It's just extremely slow. I also want to draw attention to the fact that some of these conditions on the bottom where it says other, these are all things that also need to be considered that can be present in persons assigned female at birth. There's a condition called Lamb's disease, as well as rheumatoid arthritis, cystic fibrosis, lupus, asthma, and Marfan syndrome can also cause lung collapses. So when you're being worked up for this, these are all things the doctors have to consider. So I'm going to do this really, really briefly. I posted this in case we did have some doctors with us here to learn. So we know that when you have any kind of spontaneous pneumothorax, based on statistics, and you have, let's say it's a catamenial pneumothorax, the range of diagnosis that we've seen surgically in group studies range anywhere between 30% and 70% of their persons that undergo surgery. So part of this can be explained by the fact that there is, and again, no standard for thoracic endometriosis diagnosis. So what constitutes positive, what constitutes negative? Second, we also know that there's no consistent intervention, as in what stains are being used, what are you looking at? Even today, there was a study just released maybe a week ago that was also another proposal. I've seen quite a few lately of what should we be looking at to determine whether endometriosis is present or not? Because endometriosis in the chest cavity does not present as consistently as it does in the abdominal pelvic area. So when I put in the gray, you'll see that there's a variety of things that can be looked at. And this, again, isn't exhaustive. These are just the much more common things that are considered to use as tools to try to get a positive diagnosis. The second thing is, as I talked about before, is endometriosis is often little tiny nests of cells. So a little nest of cells can do a lot of damage. And as we know, we think about the magnitude of pain we experience, right? That little bugger down there can cause a lot of problems for us. And the same goes within the lungs and the chest cavity. Other ways that they can try to improve identification is through narrowband imaging. And I do know Dr. Fogelson has mentioned using this, and this is where they use a specific kind of light within the chest cavity and across the diaphragm that can help create some illumination to be able to detect some abnormalities of the tissue that would lead them to think of endometriosis. And as well as discussed this earlier, the appearance of the disease, as we know, can range through the month. It can range in its ability to be present and then be a little bit more submissive, just like it does with hemoptysis. So now we're going to move on to everybody's favorite. I hope everybody's still with me. It's hard talking to a camera and being the only one in a room. This is really hard for me to do. So bear with me. The diaphragm, I just want people to stop and just look at the anatomy. I have to have everybody do this. As a physical therapist, this is a beautiful picture. It looks, I know it sounds corny, but it is a beautiful picture because it shows how amazingly integrated we are to create function. And what I like about it with the diaphragm, a lot of people don't really understand there are so many roles the diaphragm play. It's not just our primary respiratory function. It is core to basically so many things that we do. And it's integrated into so many other structures that it is something that we can't just say, oh, it's just your diaphragm, right? No, it's far more important than that. So moving on from that, what I want to show you here is that the diaphragm itself, as you see, it is integrated with these structures. It is integrated as another, it's not like a bicep muscle that has an attachment here, an attachment here. It has a fine specific attachment point. It's a tissue that blends into the abdominal pelvic cavity, and it blends into the muscles that control our hip flexors. So it plays a big role in postural stability. It plays a big role if you look at, there's these little holes here. It plays a big role in how blood's being distributed through our body. It plays a role in, well, I'm swallowing something and it's traveling down into my stomach. I mean, it really is an integral muscle. So having said that, when we go through symptomology, it may help you realize that's why you have that symptom. I wondered why somebody could have severe heartburn and it be because of endometriosis on my diaphragm. There's a reason for it. And so we'll explain this more. What's missing here is the pericardial sac, and that would sit right here. This area here on white of the diaphragm here is called the central tendon. The central tendon itself does not contract and relax. It is a tendon. A tendon is a part that's fused in the middle, and it's where a muscle connects. So you have a muscle connecting from one tendinous area to another tendinous area. So in the diaphragm itself completely separates the thoracic cavity from the abdominal pelvic cavity. There's only a few little holes for vessels to get through. Other than that, it seals and separates the two cavities. This is a really important thing to understand, as well as the fact that all the muscle contraction occurs on the perimeter of it, from all the way from the front of you to around to the back. So as you look at this, this is somebody being sliced in half, so right down the middle here through my head, and cut down. So we're looking towards the back of the individual where the spine is. These are the muscular little slits. You'll see that there's these two little areas here. These are the arcuate ligaments, and they wrap around the esophagus and the trachea. You also have some of the hip flexors. So there's your quadratus lumborum. Oops. This is a deep muscle in your back. It's a deep postural back muscle. And then you have these guys coming in, which is your iliac psoas muscle. These are your hip flexors. And then you have all these muscles here, your abdominal muscles. So this is really important to understand that they all work together. Let's see here. The innervation of the diaphragm itself, everybody knows C345. C345 keeps the diaphragm alive. So there's cervical. We also know that that same nerve innervates the heart. So it helps the heart pump. The phrenic nerve receives sensory information from the diaphragm, goes to the brain, just like it receives information within the heart, it goes to the brain. But it also, the phrenic nerve also sends information out to innervate it, to make it contract like the heart. So the important thing is that the brain doesn't understand, I have this pain and it's coming from something that's innervated by C345. It's going up to your brain, and your brain can easily misinterpret it as saying, maybe it's from my heart. And so your heart might start racing because you've got this pain, because the brain doesn't really always be able to separate the diaphragm being innervated by the same nerve as the heart being innervated by the same nerve. Further, there are other innervations of the diaphragm, but we don't know exactly. Depending on which anatomy book you look at, the diaphragm is also innervated by either the lower 2 or 3 thoracic nerves, so it would be T11, 12, 10, 11, 12, but others report that it's the bottom 6, so 6 through 12. So from your thoracic spine, you have 12 thoracic spine, and you have a nerve root coming out each one. Those bottom 6 ones wrap around and can innervate the diaphragm. That's important because that information is going to the brain as well. So let's say you hear a lot recently if the doctor's talking about, the ovary can send referral to the diaphragm because the ovary's got some T12 innervation. So the same nerve level in the spinal cord that's coming T12 is also from the diaphragm getting in there. So the brain may be getting a little bit of ovary pain, goes up here, and it says something from that T12 is hurting, but it's thinking, oh, it must be my diaphragm because that's T12 as well. So it shows how complicated our nervous system is. But when you look at the functions of the diaphragm, this is where I came into talking about how the diaphragm plays a role in not just breathing. It's important for our balance. It's important to bring blood flow back to the heart. It helps distribute lymph in our system to help clean up infectious disease. It plays a role in swallowing. So if you go, man, I got that lump in my throat, why is that? I feel like I got this lump at the same time as I got this chest pain or this pain in my lower ribs. That can be a play of the diaphragm having difficulty functioning proper with endometriosis, affecting the esophagus because it plays a role in its motility. It also plays a role in intestinal motility, both with its breathing, as well as just that contract or relax around the esophagus and the lower part entering into the stomach. So if you look here at the diagram here, you'll see these little red lines that I put. This is important because if you were to look at your own breastbone you have this little notch here, and if you push it, it's very tender. So that's the top of your sternum. And you go all the way down, and I'm going to show you like down to that little pointy spot, your xiphoid process. Okay, so people go, I'm having this chest pain. It's got to be my heart, or it's got to be my lung or something. It's really important that if you scroll about halfway down that, so you go over, there's a little bump here, we call it the angle of Louis, and that's the second and third ribs right here will articulate. If you go about maybe 2 inches below that, so you're halfway between that bump and here, that's about where your diaphragm sits. So your diaphragm actually sits pretty high. For the average person with breasts, it has a tendency for a person assigned female at birth that have breasts, it has a tendency to lie, if you were to lift your breasts up along the bottom of them, the crest, and you run your hand along the bottom, that's about how high the diaphragm sits. So that can give you a perspective of, oh, wow, maybe that is my diaphragm. It really does sit that high. Now that's in the middle of your body, but the diaphragm curves off down towards the bottom and attaches to those bottom ribs. It has what's called a recess. And so the diaphragm isn't all up here. It comes down and it comes down like this. And so that allows, when the lungs inflate, the lungs fill in that recess area because the diaphragm runs and it connects down into these ribs at the bottom here, and it wraps around and it forms that barrier between the thoracic cavity and the abdominal cavity. So I had a couple people that had done some study. This is Cesaroni's study that they had collected 150 people with diaphragm endometriosis. Okay, so we know first off that it can be found on both sides. So it's on the abdominal side and the thoracic side. So which is more common? It's likely to say that the abdominal side is more common than the thoracic side. How much? It's probably, we don't know. When I look at statistics again, we have to base on what the surgical centers are giving you. So there's a range of there. So it could be 2 to 1 more common, 3 to 1 more common to be found on the abdominal side. What he looked at was in 150 people, the right side had the highest tendency. So where the liver is, there's a higher percentage on the right. There was more common to have it on both sides than there was on the left. So very few people had just endometriosis lesions on that left side, but there was about 10% of them that they looked at or more that had lesions on both sides. So that's a takeaway there of saying, where's my pain located? The second one is how many lesions existed. So the majority of people that had endometriosis of the diaphragm had multiple lesions that were identified. Only 1/3 of them had a single lesion of endometriosis. So for a surgeon who's in there looking, they may be looking, let's see, there must be more than one. We're going to do a double look because the likelihood is there's more than one lesion. Furthermore, if you look at the shape of endometriosis, we know it's like skittles of rainbow of colors. We also know that there's variations in the shape. It's much more common to have nodules or endometriomas than it is to have plaques. So what they looked at in the distribution is that there's nodules, about 1/4 of those had nodules that were bigger than 1 centimeter in diameter. And about 2/3 of them had nodules that were less than 1 centimeter in diameter. And then just over 10% of persons had plaques that were at least 1 centimeter in diameter. So now we look at the depth. And most believe for symptomatic disease to be present, there's usually an amount of depth to the disease. So there is superficial endometriosis that occurs that is non-symptomatic. People can have the disease present but have no symptoms. To date, surgeons are still wondering, there's debate about it. Well, if it's not causing symptoms, should you leave it behind? Lately, I've seen more and more doctors saying, let's go ahead and remove the lesions because we don't want it to, we don't know if it's progressive disease or not, and we don't want it to become symptomatic. So we look at about just under 1/4 of people with endometriosis lesions on the diaphragm have deep disease. So these are all, this is a very busy slide. I put this on here only because, well, 2 reasons. First off is the surgeon that was involved in collecting this data, Mr. Sutcliffe, he was one of the 3 authors with Dr. Christopher Mann, who's a gynecologist in excision surgeon endometriosis, as well as Mr. Sutcliffe is a hepatobiliary surgeon, and they had a med student, Dr. Packus, who were involved in doing the first survey of people around the world to understand a little bit more about diaphragm endometriosis. So there were 136 people who participated in this survey. It occurred for an open window of about a month at the end of last year. And those people that reported, these were all people that had surgically confirmed diaphragm endometriosis. 93 of them had a laparoscopy or a laparoscopy only. So in other words, they had confirmed disease that at least they knew of on the abdominal side. And 23 of them had a surgical VAT. So they had chest surgery that saw the chest side of the diaphragm. They reported that the most common age was 27. That doesn't mean the mean. That's the most common number of people that participated in the study were 27 years old. But it ranged between an 11-year-old who participated and a 50-year-old who participated and identified surgically confirmed endo. So in that study, these are what the patients had reported. They had moderate to severe pain in these particular areas. So the ones that stood out are obviously upper abdominal, chest pain, and shoulder pain. So again, the referral of pain up into the shoulder is quite common with diaphragm endometriosis. We also have reported that 2 out of 3 of those people with diaphragm endometriosis had their symptoms begin before pelvic symptoms. And I'm an old lady now, so I can't think back that far. But it's hard for me to look at, when I was 17, the respiratory symptoms started. That was easy for me to remember because I'm an avid runner, so anything that affected running always stood out. And I can't tell if that onset before the urinary and the gastrointestinal symptoms began. But I do believe this is quite common, 2 out of 3, as well as the fact that there is carryover in the number of people and what they report in symptomology between the right side, left side, and both. About 35% reported symptoms of both sides. This is likely because even though the phrenic nerve is separated into a right side and a left side, that central area, the brain can easily misinterpret that area. And we know that anatomy is not perfect. There are people that fall within that, outside the normal limits that are still normal anatomy, but it could be easy for the brain to overflow and misinterpret that information. So now they took and they looked at the people that went to the doctor, right? So they're on their way to get a diagnosis. And 124 of them, first with their symptoms, they stopped at a primary care physician. So up in this yellow band here on the right-hand side of your screen, at their first visit, 11% of the doctors had suspected diaphragm endometriosis. I'm actually pretty impressed with that. Whether it was the patient who brought that up and taught the doctor that, I don't know that. On his literature, I could ask him, but I would be safe to assume that there's probably a portion that this is where the diagnosis came from. 53% had no diagnosis when they left. I don't know about anybody out there in Zoom land here, but for me, that was a common occurrence. And about a third of them had a variety of other diagnoses. So we'll switch over here to the other diagnoses circle here. And as you can see, that even includes gastrointestinal disorders. And as we mentioned, there are the functions of the diaphragm. We also know anxiety and stress. We know that. And we also have a tendency to see, oh, you pulled a muscle. So how many visits did it take? Well, the most common out of the people was 10 visits to their primary care. 10 visits. That's a lot of copays in the United States. It's a lot of testing too. But it ranged anywhere between 1 and some people said 100. So how long did it take to get a diagnosis? So the median, again, the most common reported was 2 years, but the range was anywhere between immediately at the time of their first visit up to 23 years. So given the fact that it's an average of 2 years to get a diagnosis, we see about almost 1/4 of them, it took over 5 years. And I can tell you, somebody who's experienced it, it's not a fun thing to handle, right? So there were 14 of these people who went straight to the GYN and started looking for a diagnosis. So they referred themselves. Of those, over 31% of them took over a year to receive a diagnosis. Of them, it took not 1, but at least 2 or more laparoscopies for a diagnosis to be achieved. And this ranged up to 12 laparoscopies. So something's not right in the surgical world that we need to address. There were also, out of 14 of them, 3 of them were misdiagnosed. And I thought these were quite interesting misdiagnoses of ovarian cyst and miscarriage. So what does it feel like? First off, is catamenial is the number one clue. And this does change as the disease progresses. But these are the most commonly reported conditions that we have seen. We have done surveys in our support and education group, and these are very common presentations. So as you notice, the sensation of choking. Again, think about the esophageal motility that the diaphragm plays a role in. Nausea, again, the diaphragm plays a role in digestion, esophagus. So it's easy to develop that sensation like you have GERD or you have a hiatal hernia, and so you're having gases escape up into your throat. We also know that there's referred pain to the shoulder. This in part is due to that C345 distribution, most commonly on the right, but it does occur on the left. So we also have to consider other tissues like the liver and the gallbladder also refer to those areas. And hiccups. This is a really unique one. We do see a lot. There's a lot of hiccups that happen. So I had people reach out and say, well, describe it to me. Oh, it's just this pain. It's this pain. And this is what the doctors hear, the pain part. But what they don't really hear about is something that qualifies their pain, that they can describe it. You know, when you say, man, it's a 10 out of a 10 pain, or it's a 9 out of a 10 pain. These are things that people have expressed to us, where, you know, a flaming hula hoop around my midsection was worse when I was breathing, or being punched and like a constant toothache, like that deep, dull ache. You know, for me, I had the furnace that somebody set the furnace on fire, and it was coming up. No matter what I did, it was like no antacids could calm it. I like the hot lance poker, that you could stick a hot poker through and it would travel all the way through to underneath your shoulder blade in the back. That is very, very common. That's like behind the shoulder blade. That's not like below the shoulder blade. It's like you feel like it's coming through your chest. So diaphragm endometriosis is one of those areas like pelvic, abdominal pelvic endometriosis. You know, it may start on a couple days around your period. And then over time, you know, months to years go by, oh, it's growing around my period, and it's starting to show up around my ovulation time. Over a period of time, now all of a sudden, it's ebbing and flowing through the month, and it never goes away. And part of that is because you also have to think that the disease is changing course. If you have progressive disease, it's becoming fibrotic. It's taking on a different composition. And with fibrosis and adhesive disease, the fibrosis, it limits the diaphragm from excursing. It's not able to move as function. So it doesn't function as well. It doesn't expand as much. And you got to think that the area around it, even if there's no vascular or neural structures in the scarring of fibrosis, that the area around it is not a happy camper because it's not functioning normal. And sometimes with repetitive movement or stretching, it can improve the more you use it in a day-to-day basis, but it's always going to be there. It's always present because that fibrosis is there. It's the same with adhesions. If you're having adhesions to the chest wall, or you're having adhesions to your liver, you may find that, you know, trying to side bend, like when I would drive and I would try to lean my elbow on the armrest while I was driving, you know, I got those really uncomfortable pains. Like I'd get nausea in my stomach and I'd get those sharp pains. Or if I rolled over on my stomach, you know, I rolled over to the left side and my liver would hang, I'd feel those sharp pulling pains of my liver. So with certain movements, you can get that sharpness that occurs even when you're not on your period. And those are signs that's showing that, you know, there's some fibrosis going on and or adhesive disease. So when it comes to the diaphragm, this is huge. We talk about referred pain. We mentioned the C345 of the heart and the diaphragm, that the diaphragm will refer up into the right shoulder area up here in the neck. It can go up into the ear. It can also overload and go down into the shoulder. So this is what we call like segments that go to the brain, and the brain misinterprets it. And because the pain magnitude is so high, it can skip, it can overflow from C345 into other dermatomes, and which basically means location on the body that you feel the pain. And that's why some people feel it down into their arm. So if you look here, the liver and the gallbladder are also commonly referred up into this area where people say, I got this pain up here. So those are areas that also need to be worked up for your condition. So, they may say, let's check for gallbladder disease. So when you were to run down, it's not just those areas that cause pain in that right upper quadrant or that lower right chest. These are other things that need to be looked at. And if you have disease on the left side, there are also things like the pancreas that need to be considered. And some of these other diagnoses should also be worked up if you have pain going to the left side. But overall, I wanted you to just see that there are a variety of conditions. And so some of these are far more probable to exist than thoracic endometriosis. So it's really working with your provider. Taking a diary, a journal of what's happening to you is really, really important, because we need to also know on their end, there's a lot of things that they have to consider, and not just thoracic disease. Having said that, the one component that will help you if you think that you have diaphragm endometriosis is that journal. Keeping track of when the symptoms happen. If it's around your period, and then you're noticing it around ovulation, there's a calendar. Keep a calendar of it. Also record it on a body diagram, where you're experiencing the pain, what that pain feels like. This is really important to show that repetitiveness, that cyclical component does say a lot about the potential of it being endometriosis and not one of these other conditions. So for example, if you have a gallbladder condition, a lot of times that'll appear birth control, use of birth control increases the risk of gallstone formation and gallbladder disease. As well as we know, it's just more prevalent in general in people assigned female at birth, because our estrogen messes with the gallbladder. It's not our favor. The second thing is that gallbladder disease has a tendency to show up after you eat meals, particularly desserts and high fat foods, that you'll have some of those pains from the gallbladder. So these are all things that you need to consider. So we have anything from musculoskeletal, spine conditions, to gastrointestinal issues, to cardiorespiratory issues. There's a boatload of things. So that is why I provided this slide here. So if you think you have endometriosis and you have your doctor say, I want a laparoscopy, and you have a general GYN take a laparoscopy, this is something that I want people to see, because this happens all the time. I had my regular gynecologist take a look at my diaphragm during a recent laparoscopy. He said it looks fine. The entire diaphragm cannot be viewed through a standard laparoscopy. So here's your diaphragm, this beautiful thing here. This is your liver. The liver is the largest, next to the skin, organ in the body, per se, next to the intestinal tract. Okay, we'll give that, but the bulk of it takes up, a large space, and that covers a large portion of the right side of the diaphragm. So in order to view these areas, there are a few alternate techniques, and not all techniques are required for every person who undergoes a laparoscopy. It just depends on your own morphology. So for example, reverse Trendelenburg is something where when we are in having a gynecological surgery, usually we're tilted this way with our head down. So I have the little individual here with their head up next to what's called reverse Trendelenburg. And what that is it's tilting you towards your head up. And when your head is up, some of these, the liver tends to kind of go with gravity and it falls away. But the liver is still stuck in place, and it's not a true ligament. It's really a fold of a lining, peritoneal lining. It's just a thin layer that lines all our organs and the internal cavities. So you can take, the surgeon may take a little retractable thing to help pull the liver down. And for some people, that's perfect. They can see what they need to see based on their morphology. Other people, they need to have this falciform ligament snipped, which is with this little pair of scissors I put here. And this little guy is that little ligament. And they may snip it off, and that allows them to further retract the liver inferiorly so they can see. Some surgeons may choose to use additional ports to look, and that may mean up here. So your belly button's kind of down here about this level, and they may want to add a port here to look, or they may want to add one on the right-hand side of below your ribs. And the last one is having a specific kind of scope. Dr. Sonardo had mentioned that 35-degree angle scope works really good at allowing them to peek around and see behind the liver. So for most people, this works. I do know that there are some cases that I have seen surgical studies and have talked to surgeons about that. There's some alternative approaches that need to be taken for some disease, but it's not the regular occurrence. So again, this is very, very common that I see, and it's very, very frustrating to me. It's just angering because I feel like it's a deception to you as a person looking for answers. When a gynecologist tells you they have performed their laparoscopy and said, well, your diaphragm and lungs look fine, and you just had laparoscopy. And I feel like they're unloading onto the patient and thinking that the patient isn't smart enough to know that the diaphragm interferes with the ability to see the chest cavity itself. And that even though there are holes in the diaphragm, so if you look at the green here, there's actually 3 holes here. These are where our great vessels run through, as well as some important neural structures like the plexus of your nervous system, you know, your esophagus, your swallowing tube, the aorta that has the good blood going to your body, the vena cava with the bad blood, the old blood going up, and they pass through these holes. There's not much room there for a camera to go through and look. Second, the laparoscopy, a normal gynecological approach, is at the belly button. So they'll do their little scope and they'll put it up here. So they're seeing everything from this approach. So looking at the blue line. So the liver, if you remember, covers this whole area. It will see the front half that you see here, but it will not see the back half. Hence why the maneuvers like the inferior pulling the liver down, or using the extra portals, or the camera to peek, and the tilting the body, those are all ways that kind of help you see the back of that area, but you may not see the full area. And to be honest, most gynecologists don't do any of these. So therefore, when you have a doctor tell you that, first off, did they even see the whole diaphragm? 99% no. Second, did they see your lungs and the chest cavity? No, they did not. So wrapping things up, what do you do for yourself? If you're here, I have symptoms and nobody's listening to me, how can I advocate for myself? On my homepage at extrapelvicnotrare.org, I have a PDF, downloadable PDF that you can click on, and it's on the homepage, and you'll want to scroll down below this animated video on diaphragm endometriosis. You click on that, and it is a loaded content. It has a body diagram. It has a 1 to 10 scale that I like to use because it relates function to the number of restriction from 0 to 10. And I found that every day I had symptoms, I reread that every single day to see where I was on that symptom scale, because it helped me put my function into real terms of how limited my mobility was. Second is knowing that imaging is not 100% conclusive. You can have disease without it being apparent on imaging. And we do know for some studies, they've reported that if you have imaging at the time of menses, for certain conditions in certain locations, that imaging increases that probability of just being on your period. We also know that the radiographer's experience with endometriosis lesions is important. So when we actually say, well, what imaging should we get done? First off, the CT scan is for lung parenchyma. You'll see surgeons a lot of time, if you go to an endometriosis excision surgeon, they'll order a CT scan lung scan because it helps them rule out other conditions, and it also helps them see your anatomy. There are people out there that have some abnormalities, so they want to rule out that there's not something mischievous going on, that there's no cancers, there's no unexplained tumors or another disease present for your symptoms. Second is that an MRI, the ratios are 78 to 83% of people with diaphragm disease. The MRI can detect endometriosis in the area. Now, this has to be taken with a grain of salt. And the fact that the sample only provided persons that were having A, symptoms only at their periods, and B, their symptoms were resolved with the use of birth control. Those were the only people included in this study that reported the sensitivity to determine the validity of MRIs for diagnosing thoracic disease. As many people with thoracic disease know, that that's only a small percentage of people with disease because their symptomology increases through the month. So it's there longer, but at the same time, also the composition of the disease changes. And the MRI is really good at soft tissue disease, and it's really good at identifying blood products. And we do know as the disease evolves that the composition changes, and therefore detection on imaging may also change. So it's taking that at a grain of salt, that no imaging is 100%. The last thing is if you suspect diaphragm endometriosis, it is important to go see a collaborative excision team, because we do know that oral medications, gonadotropic releasing hormones have fair efficacy for those with catamenial hemoptysis, but the other forms of endometriosis, their presentations don't do well with medical management. There may be a reprieve while you're on them, but there is a tendency for the disease to return following that. Having said that, I would take your medical records and have them sent for an evaluation. And that includes all of your surgical reports, any photographs. And most importantly, I say is the own work that you've done with the body diagram and keeping track of your symptoms and including that into what you submit. So we're wrapping up. So our summary is that the endometriosis of the respiratory system to date is the third most common. We don't know its true prevalence. There is no tracking systems from local to global in place. We do know that there are other things that are catamenial, like catamenial asthma, there's no endometriosis in the respiratory system, but you may have shortness of breath during your menses. We also know you may have nosebleeds during your menses. That is not due to nasal pharynx endometriosis. The biggest differential there is the presence of pain with your monthly nosebleeds are usually an indicator that endometriosis may be present, but no pain, but recurrent is just a common result to capillary instability due to the fall in estrogen. There's a tendency of right-sided lung collapses as well as right-sided symptomatic disease in general, but we also know that it occurs on both sides. As well as imaging can be completely normal, but that doesn't mean disease doesn't exist. We know the diaphragm is by far the most common area. Abdominal side tends to be more frequent, probably in a 2 to 3 ratio, or 3 to 1 ratio, 2 to 1. We don't really know the estimate, but it is more common on that side, as well as superficial being more common than deep disease, and multiple lesions being more common than single disease. We do know catamenial hemoptysis, as I said, it does well with medical management, and sometimes it can actually prevent reoccurrence from occurring after you discontinue that. If a doctor tells you it's too risky, or that you want you to get a hysterectomy and have your ovaries out, please get a second opinion. The side effects from a hysterectomy, there's a lot of long-term things that occur that, although there may be an immediate relief, the long-term outfall of having these things as you age are something that I would encourage you to seek getting the disease taken care of with the right team. The surgery can be achieved successfully, and you can move on past this phase in your life. And with that, the best probability to prevent the recurrence is having a combined lap VATS surgical procedure. So as I mentioned before, this is recorded, and if you will find a slide that you're interested in and you want the resources, these are how they're identified. And with that, if you have any questions or concerns, these are ways to contact me or follow me. And I do appreciate everybody hanging with me as I stumbled through everything. So thank you very much. Hi, Bianca.
Hi, thank you, Wendy. That was amazing.
Well,
We've had
best we could do. I can't see anybody. It's just so hard talking to something that doesn't talk back.
Yeah, well, we've had a lot of interactions via the chat box. You're able to, I mean, if you want to stop sharing your screen, and
Yeah.
you can kind of just see all of the comments. We have a lot of questions. And then I figured, just for the sake of time, I can definitely send you these questions, and we can actually share it in a follow-up email, because we have a lot of questions. And I think it'd be great to, you know, all of those responses from you, and I can definitely share it to all of our attendees. But just some great comments.
Were we able to get the survey up, or did that not?
Yes, so I'm gonna actually I'll go ahead and put it up now, so at least we can get the survey done now.
We lost a few people here, but that's okay. Yeah, so those that are still with us, if you'd like to participate, it's always fun. We wanted to do it before. How do we do this?
So I'm gonna actually, I'm gonna launch it. So it should pop up at any moment. So there's actually going to be 2 surveys. So the first one will be launched right now. So just a couple of questions. So just be sure to go ahead and respond to those.
Are you ready?
And it is launched.
Those that are still alive here.
Now.
Oh, there's some people that can't vote. Oh, that's right. 2 of us. Just curious where you're coming from. Yes, it's so hard to talk to a screen and not have, I do so much better when I have eyes. Eyes. Canada. Yeah. Canada. Africa. Hello.
And Jessie, if you can't hit submit, try to
healthcare professional. Yay.
See if it allows you to exit and then re-enter the poll. If not, that's completely okay.
Okay. So yes, there's a lot with symptoms. So what you can do is end the poll, which I ended, and then you can do that. So you see this stop.
Should I relaunch it?
So give you no, it's all been collected. We'll go on to the second one here. So we do have quite a few that have symptoms, and they're thinking about that. That's really important, that those are the ones we want to catch. So we're going to close that. And then you had, let's see here, the second one. Here we go. Poll number 2.
Okay, so it should be launched. Feel free to answer these questions. And I apologize if I misspelled anything, Wendy.
You've learned something too today.
Yes.
Yep, that's still going. Let's see if it should pick it up here. Let me see. Attendees are now viewing questions. So yes, might take a while to read. They should be viewing it out now. Viewing.
Let me know if anybody's having any technical difficulties.
Are you all in the chat? Oh, there it goes. Okay. Oh, wait. Okay. 1, 2. Oh, here it comes through now. I don't have an all of the above button.
I'm not too sure why it's not letting you submit. I apologize for that.
Oh, it's taking it right now. Is that what you're looking at? Second poll's going.
I have a couple of attendees that are not able to submit, but thank you for letting me know. Oh. I'm still learning when it comes.
Okay, so, but isn't it? It's fun. You're learning something new. We're all learning something new every day, right? Yes. Hold down in order to submit it and answer all questions. Okay, so if we're looking at these, so it looks like that's as many as we're going to get. So let's end it, and let's share the results, and let's have a look. So shortness of breath, and the shortness of breath. It's what's really important is that we look at not just look at the combination of what symptoms you have as a cluster. So for example, if you're just having the shortness of breath and you're not seeing other things, you need to also consider, right, other options. Even the pelvic floor can cause shortness of breath. So we know, for example, with endometriosis, if you have abdominal pelvic endo, and let's say you have some adhesions and they're binding things together, and then you have some pelvic floor issues, and we know the pelvic floor is tight. You saw on the anatomy diagram that the diaphragm is here, and the anatomy, how it integrates, and it's like a tube. So when the diaphragm drops, when you breathe, the pelvic floor has to open up. It's got to absorb those organs going down. Well, if you first off have adhesions of those organs, when the diaphragm drops, it's got this resistance. So you're having to work to get a breath in. The diaphragm can't work as smooth as it wants. So you're going to feel like you have some shortness of breath, one, because maybe you can't quite get a good breath because those organs aren't descending. So in addition to the organs being stuck with adhesions, you could have concurrent pelvic floor issues that, believe it or not, that pelvic floor descends, it relaxes a little, just enough to allow the diaphragm to move. So they have to work together. So I do tell a lot of people that make sure that you're ruling out that you have some pelvic floor issues or some adhesive disease that are adding to any shortness of breath. And even I even had there's some referral from, like, say, the sacroiliac joint area. When I was having pelvic floor treatment, I was getting referral up into my diaphragm area from the pelvic floor, and this was after I had the diaphragm removed, endometriosis removed. So that's really important, is to look at these other options too and explore. And again, you mentioned the shortness of breath. Looking at, do you have catamenial asthma? That's a distinct possibility to look at, because we know estrogen affects the way that the lungs function at the time of menses versus when it's outside menses. So let's have a scroll down here. Yeah, so that mid upper chest, yes, down towards the ribs, chest. Yeah, hiccups. Yeah, it's, and the heartburn. Again, this is one that I think a lot of people I speak to have it, and I know a lot of surgeons have not been aware of that their patients have had heartburn. And so it's educating them, as well as them saying, here's all your antacids. And when you have the heartburn, you have the pressure, you have the shortness of breath, you have all these things going on. So that cluster, and it's catamenial. So those are all components. And the fatigue. Oh yes, we all have that, right? It's so awful. So in the days immediately before interventions, I used to currently experience one or more of the following. So some of you have had pleural effusion, have had very little. I've had imaging, and none of the above. So yes, what we're seeing there is, even though this is just a small sample from everybody watching, and obviously we're going to have more people interested in this session that haven't been diagnosed with disease, that it is the most common presentation, is that catamenial chest pain without having these. 3 out of 14 did have imaging. And again, imaging, unless you have a manifestation that shows up, they can do MRI imaging. What we're finding is very people actually get the MRI. We know that the X-ray is the cheapest, and then the CT, and the MRI is significantly more expensive. And in some countries, you can wait a year, 2 years, and you don't get to choose the time of the month that you attend and have the imaging done. And when you have the imaging done, it could come back negative. So this is a very frustrating disease for people, because you feel like it's like this, we hear of invisible disease, but thoracic endometriosis in particular is more invisible. And then symptoms, and that's about right. Yeah, left and right. It is a common occurrence. So yeah, I thank you. I appreciate this. But yeah, I hope I didn't stutter too much. I prefer live presentations, maybe one day.
No, this was really great.
And I would be glad. I can type in and respond to those. Are you able to pull those off and email them?
I'm creating a list of questions. So we have plenty of questions that Wendy will go ahead and hopefully respond for us. And I definitely want to just send those out in a follow-up email to everybody. And I just really appreciate everybody for taking the time and being here. Lisa noted your presentation was awesome, Wendy. So it's just, we're just so grateful to have had your expertise and your knowledge today and tonight, and we're just really appreciative of it. And if you have any final words, Wendy, for us.
No, I want to thank everybody that stuck with me through this. I kind of mumble over my words because it's been a while. Yeah, we need to get back into the groove of public speaking and yeah, and what I want to say, I'm better off the cuff than I am having to be adherent to my slides. So
Well,
no,
thank
thank you
you.
everybody for attending this Zoom land and wherever you are in the world. So I wish everybody the best, and I hope that the resources I offer on my website or in the support group will help you find the people and the answers that you're looking for with whatever might be causing your symptoms. So good luck to everybody.
Thank you. The presentation
Alrighty.
and the recording will be uploaded on our YouTube channel. So just keep an eye out for that. And I just wish everyone a wonderful rest of your evening. Thank you everyone for joining. Bye everyone.
Awesome.